I got help. I went to the only treatment facility in New York City at the time that specialized in perinatal mental health. I started therapy. I started medication. I'd say, within 4 months, 6 months, I was starting to feel like myself again. And it was at that point where I got pissed.
Welcome to our podcast, where the rarely spoken truths finally get loud.
I'm Megan Nelson.
And I'm Pauline Walfish, and this is a therapist-led podcast.
We're naming the messy parts of life without judgment. Welcome to What No Mom Told You.
Welcome back, everybody. If you are new here, I'm Pauline Walfish. I am here with my faithful co-host, Megan Nelson, and a really special guest today. So, Megan, would you introduce our guest?
Absolutely. Hi, everyone. So, did you know that perinatal mood and anxiety disorders, or what you might hear us say, PMADs, that they're the most common complication of childbirth, but so many new parents suffer in silence, confused about whether their experience is normal or not? So today's guest has spent over 25 years fighting for marginalized communities and families, but her work shifted following the birth of her son. After surviving severe postpartum depression and anxiety, she turned her lived experience into action by drafting legislation that became New York state law, requiring birthing hospitals to screen for perinatal mood and anxiety disorders. She went on to co-found the first perinatal partial hospital program of its kind in New York State, and has since built a career focusing on policy, clinical care, and advocacy around the perinatal mental health. Please welcome today's guest, Paige Bellenbaum. Welcome, Paige. Nice to have you today.
It's such a pleasure to be here with you both. I'm really excited for today's conversation.
Paige and I first met, I guess back in it must have been around 2009, 2010, when the Motherhood Center was just getting started. And I was working in a perinatal outpatient program, and Paige came with Dr. Berndorf.
You got it.
And they were talking about this new partial hospital program that they were opening in the city just for pregnant and postpartum women. And we were drooling over the idea and the possibility that something would exist for the people that we were serving. And I fell in love with Paige and her passion right there in the halls of the outpatient clinic. So it has been a privilege to get to watch her career really thrive and all of the amazing things that you have done for perinatal mood and anxiety disorders and the people who live with them. So thank you. And thanks for being here. But let's get started. How do you describe to people what a PMAD is?
What does it mean? What is it? And Pauline, thanks so much for your kind words. And I remember that first moment vividly. And I'm so glad that we have been able to work together so collaboratively over the years.
Yeah.
So what an important place to start. What are perinatal mood and anxiety disorders? Acronym for that, PMADs. Interesting to note, though, the conversation is changing around what we actually call these conditions.
Mm-hmm.
It seems to be moving a little bit over to perinatal mental health conditions, perinatal mental health. So if I use that interchangeably throughout our conversation today, that is why. But for the sake of sticking with PMADs, I like to think of it as an umbrella. And underneath it sits a series of different diagnoses that a pregnant and or postpartum person can experience in the perinatal period, right? And important to note that when we're speaking of perinatal, we're talking about from the moment of conception all the way to 1 year postpartum. Caveat to that, though, somebody can still struggle beyond the 1 year if they haven't received appropriate treatment and care.
And also after a miscarriage as well.
Absolutely. Thank you for that, Megan. So the conditions that we consider to fall under the PMAD umbrella are perinatal depression, perinatal anxiety, perinatal obsessive compulsive disorder, perinatal post-traumatic stress disorder, bipolar disorder, and perinatal psychosis. Now, as we know, and many of your listeners know, there are different symptoms that go along with each and every one of these different diagnoses. But I think just to take a step back, what's important to note is that statistically about 1 in 5 women and birthing people experience a PMAD. And what I always like to say, and I don't have research to back it up, so that's my qualifier, qualitatively speaking, just through experience, and when we take into consideration that 75 to 80% of all women and birthing people do not come forward and talk about what's going on with them because of the shame and stigma that surrounds perinatal mental health, I would say it's probably more like 1 in 3. And we know that PMADs are the number one complication associated with childbirth, as Megan said. And we also know they're the leading cause of maternal mortality in this country and here in New York. So hopefully that provides a little bit of context for all our listeners.
Yeah. Because this is the work that we do all of the time, right? We're really familiar with that. But that statistic, I think the general population doesn't realize just how much, right? So the numbers that we use is 1 in 5. It's probably more than that, depending on the research studies. Sometimes they have a different 1 in 6, but in general, we use 1 in 5, probably more because it's 1 in 5 that we've detected or that people have disclosed. Even in those 1 in 5, not everybody gets help, or they get some help, but not enough help.
And it's 1 in 5 pregnancies, not people. Many people have more than one pregnancy.
And what we know to be true about PMADs is that if you do experience one during an initial pregnancy or postpartum, you're at a significantly higher risk of developing one again. So all important things to consider when we're having this conversation.
Yeah. And the number one complication and the number one cause of death, right? We talk about maternal mortality and there's all fancy statistics, but that really just means moms who died. You know, I think back, it's been a minute since I was in the OB's office for taking care of pregnancy, but I know they screened for diabetes, they checked my blood pressure. Again, we have come a far way, so I know that more and more are screening for PMADs, but I still don't think it gets quite as much attention as gestational diabetes.
No, I was screened twice for gestational diabetes and once for PMAD.
Yeah, you're absolutely correct. And one study I saw, the combination of gestational diabetes and hypertension rates combined do not equal that to the rates of women who experience PMADs. And the other thing I would say, based on HEDIS measures from a couple of years back, the statistics even around screening was for Medicaid patients, like 16 to 17% were being screened. And for women with commercial plans, it was even lower, from like 9 to 11%. So yes, you are right, Pauline. We have come a significant way from certainly when I had my first child 20 years ago. I'm dating myself here. And yet we still struggle to close the gap in care and support for pregnant and postpartum people.
Yeah. And that PMAD term, which we started this before the term PMAD even caught on, right? Because it used to just be postpartum depression. And then everybody was like, wait a minute, there's so much more than depression. And that's how this like umbrella term moved from postpartum depression to PMADs. But even under that, there's postpartum psychosis, which is very different than depression and anxiety. And so it's under this umbrella term, kind of fits, sometimes maybe. And so I think really talking about mental health in the perinatal period is so important. You know, even I know in a recent training we did, we talk about adjustment disorders that don't fall under the criteria of a major depressive disorder, but still have an impact on folks, especially new parents. And somebody was like, I never heard an adjustment disorder be considered a PMAD. And we're talking about depression and anxiety in the perinatal period. So it's such mental health is broad. It can look so many different ways.
It can. And I think it's really important that you identify where we originated, right? Because there are still a lot of people who will refer to the term postpartum or postpartum depression as a catch-all. And as we started with, we understand that there are several different conditions that fall under the umbrella of PMADs. And when we call everything postpartum depression, then we are missing a large number of different diagnoses. And I also want to clarify, especially with everything that's going on in the news, when we refer to perinatal or postpartum psychosis as postpartum depression, then we are risking combining these two conditions and creating an even larger wedge in fear for people who might be experiencing perinatal depressive symptoms of, if I come forward and say I have postpartum depression or I'm having these symptoms, they might think that that's what I'm capable of. So the distinction between these illnesses really is key.
Yeah. And I know that I think maybe you're involved in some of the action behind it, trying to get a DSM-5 diagnosis specifically for postpartum psychosis. So for the non-therapists who might be listening, DSM-5 is like the encyclopedia of all mental health conditions. And postpartum psychosis doesn't exist in it right now.
DSM-5. Yeah.
There you go. Bringing it as show and tell.
Yes. It's well flipped through, right? Yeah. I'm interested to know how you see it being in the DSM-5, how that would change things.
I think it would change things because we would have a scientific and psychiatric term for it. I think when we have specific diagnostic criteria, we'll be able to catch it more. I think a lot of, when we look at the numbers of psychosis cases, first of all, it's an area that's completely understudied, but we see numbers like 1 in 2 per 1,000 births. Now, having worked at the Motherhood Center and started that program so many years ago, as a perinatal partial hospital program, we were really a feeder and step down from inpatient psychiatric units. So patients that were actively psychotic but stabilized, patients that were suicidal or had an attempt, were coming to us for that higher level of care because they weren't appropriate for an outpatient setting. They needed more. So just based on 10 years of being in that environment, I would say at any given moment, we might have 5 to 7 people in a cohort that experienced perinatal psychosis. So I think having an appropriate diagnosis so that people can receive that diagnostically, even looking at what's going on in the news right now, having something that has been accepted as an actual diagnosis would help us start to understand the condition better. And it would also allow us to capture the true number of people that actually struggle from this condition.
Yeah. I think it's under-recognized. And I think so many more people have some spectrum of a psychotic symptom because it is a spectrum that either providers don't catch, they don't talk about, they keep it hidden, and they never tell anybody that they were having that happen, or that, like so many women who have postpartum psychosis, providers, loved ones, clergy are always searching for some other reason that this thing could be happening. And so giving it more of a legitimate name could give people an okay to be able to diagnose something.
Absolutely.
And change treatment too. When we think about like Europe, and I know it's not everywhere, but there are centers like mom and baby centers for treating postpartum psychosis and other disorders where that it's accepted that this is something to treat really mindfully. And that started with having this diagnosis, right? It starts with saying, okay, we're going to recognize this and then put money into it. When you don't have that, it's like, who puts money into it?
I'm so appreciative, Megan, that you brought that up because as much as we have made progress here in the US over the past several years, when you look at other countries like Europe and several countries in Europe, they have these mother baby units that you speak of. And not only are they recognizing this very specific disorder of perinatal psychosis, but they are true mother baby units. So that means that mothers are getting inpatient, long-term psychiatric care with their baby. And there's a focus on dyad, attachment and bonding. And we don't have that level of care here in the US. We have, I believe, 5 women's inpatient psychiatric facilities that have a perinatal component, totaling, I think, maybe 26 beds in all, if you add it up. So we are woefully behind our European counterparts when it comes to effectively treating this illness in a way that allows for that connection between mom and baby to continue to develop in one of the most critical times.
Yeah. Yeah. I remember being at a PSI conference. I think it was the time where we actually toured the first mother baby perinatal unit at UNC, which I was so impressed. Like, they do allow the baby to come to visit, but it's not what they have in Europe where the baby's there all of the time. Anyway, we were in one of the breakout rooms and somebody raised their hand. They're like, "I'm from Canada. We are allowed to admit moms for sleep." And everybody in the room was like, "Oh, that's amazing." Because here in the US, like, the criteria for inpatient treatment is danger to self or others. And up until there, for many people, like, you're on your own, right? And so what happens if we actually change the criteria for inpatient treatment to an illness that requires intense monitoring and care? And not necessarily about danger. But we're not there yet. You're working on it, though.
Someday, I have hope. I do have hope that in my lifetime, in all our lifetimes, that we will see that. I know that there are obstacles, but I believe those obstacles can be overcome. And I think this is such a pivotal moment for everyone in the face of perinatal mental health, especially acute perinatal mental health. And I do hope that with everything that's happening, that there is hope, there is a silver lining, that we will really start to pay attention to the complexity of this illness in particular.
Yeah.
And that we will follow through with programming, with systems change. That is my hope.
And you are doing a lot to make that happen. I don't want to skip over your story because I think it's so meaningful for people to understand who you are, what happened to you, and how that put you on the trajectory to where you are today. So can you share with us how this became so important?
Yeah. So I've already dated myself in our conversation. So 20 years ago, I gave birth to a beautiful, healthy boy. And when I look back in retrospect now, I realize my anxiety developed during pregnancy. I was that person who was calling my midwife multiple times a day because I didn't feel the baby move, or her favorite was, "My right breast is no longer tender. I think that maybe I'm losing the baby." So I was completely fixated on all of these things that I couldn't see happening in my body.
Yeah.
And then by the time he got there, my anxiety developed further, as well as the depression. So I was not sleeping. I was not eating. I had lost most of my baby weight within the first month or so after he was born. I was convinced that he was going to die, that something terrible was going to happen to him. And so I would say the anxiety led immediately after he was born. He wasn't sleeping enough. He wasn't eating enough. He was sleeping too much. And then it really plunged into a pretty dark depression where I didn't feel connected to him. I felt like I'd made a huge mistake. I wanted my old life back. I wanted to buy a one-way ticket and fly away to a country and never come back because I felt like my son and my husband would be much better off without me. I stopped being able to really take care of myself and was just barely able to take care of him. And then it began to drop further into suicidal ideation. So ways that I could not be here anymore. And it all culminated one day where I had decided to leave the house. I hadn't been out in a really long time. And we were in a apartment in the East Village without air conditioning. It was like 95 degrees out. And I remember pushing my son in the stroller, and it was kind of gray and overcast, and everything just felt so bland. And as I got closer to the sidewalk's edge, I saw this bus coming out of the corner of my eye. And I had this enormous urge to throw myself in front of the bus. It took everything I had to not follow through. And I remembered that as the bus passed slowly, not so slowly, I saw a reflection of myself in the window, and I did not recognize that person at all. I didn't know who it was. And I knew that I absolutely needed help. And what's interesting about my story, and this applies to clinicians everywhere, regardless of your licensure or degree, I was a trained clinical social worker that was able to identify mental health conditions in other people. But when it happened to me, I had no idea what it was. So I got help. I went to the only treatment facility in New York City at the time that specialized in perinatal mental health. I started therapy. I started medication. I'd say, within 4 months, 6 months, I was starting to feel like myself again. And it was at that point where I got pissed because I had been speaking to a whole lot of other mothers out there that were in it, that were struggling, that had struggled. And there was way more shame and stigma back then than there is now. And I was like, what is going on that we are not talking about this? So I started researching legislation. Is there any state, is there any city that's doing education around perinatal mood and anxiety disorders? And I ended up drafting model legislation on screening that I took to a state senator who I'd done some policy work with in the past, because that was really my background as a social worker, was in advocacy and policy work. And I was like, listen, this happened to me. It's happened to a large percentage of women that I have spoken to, and we need to do something about it. And she said, let's do it. So we spent about 4 years getting that bill ready for introduction. And then it was finally signed into law in 2014. But that really started my unflappable commitment to ensuring that other women do not have to struggle silently as I did. I kept all of that a secret for almost 9 months. I mean, didn't feel like a secret to me. I felt like everyone around me could tell that I was absolutely decompensating. But, it's just such a reminder that people don't know what to do.
Yeah.
Right? My husband didn't really know what to do. He didn't know what was normal and what wasn't. You only have 1 6-week visit with your OBGYN. And at that point, I just wanted to get out of there.
And they want to talk about birth control.
They want to talk about things. Yeah.
I asked a doctor at 6 weeks, 8 weeks, 1 year, like, hey, do you know someone I could talk to? And they say, no, I don't. So it really, and this was a while ago, 14 years ago, but hopefully now maybe it's a little different, but
Yeah.
Did anybody ever, you said you didn't recognize what was happening to you. Did anybody in your family, friends, did anybody say did they ask how you were? Everybody asked about the baby. Did anybody ask how you were doing? And did anybody say what's going on?
So one of my symptoms, if you will, is that I really didn't want to be around anybody. I didn't really want anyone coming over. I didn't want anyone to see me that way. I just had no interest in pursuing any relationships. And so my parents certainly thought something was up, but people think it's baby blues, right? This is just part of the transition to motherhood. And love my mom, and she would always say, this too shall pass, which still rings in my ears as like the thing you never want to say to somebody who's struggling, right? Because it completely eliminates and annihilates the moment they're in that moment.
Yeah.
She didn't know any better, right? Like nobody knew any better. There was one woman, a friend of ours, who came over to visit once, and she was like, I don't think you're okay. and told my husband, and she was the only person who I felt really saw me. I will never forget that, right? Even though that might not be a wonderful thing to hear, I felt like somebody saw me for the first time. And in that, I found a little bit of resolve to move towards doing something about it.
Yeah. Was there a reason why you didn't tell anybody or why you kept it a secret for so long?
Shame, judgment. I was fearful of what people would think of me. I was in such a deep relationship with my anxiety, along with the depression, anxious about, and maybe even a little paranoid, like, what will people think if they know I'm having these thoughts? Or really embarrassed, feeling like a failure, feeling like I'm not cut out for this, right? That my duty as a mother to be able to do this thing that women have been doing since the beginning of time, that I was failing at. Also, like, nobody was talking about it. So I felt like I was the only person, as still 20 years later, so many women do. It's just me. I'm alone in this. Nobody else is struggling. And I also kind of felt like, how could people not notice? I felt so different. But in that, I share this in reflection to the work I went on to do clinically. Even women who might appear to be the most put together. I remember women would enter, at the Motherhood Center and sit on the sofa and would be like so well put together. It'd be like, is that a reporter? Like, who is that? That was our illest patient. So this pressure to perform and to look a certain way so that nobody will know this deep secret that you're carrying, which I think, so many women can relate to, but those were all a lot of the reasons why. And denial, right? What we know about PMADs, and I think this is important because I run into this a lot clinically as well, is I did have good days sprinkled around. And when you have good days or a good few days, it makes it that much harder to think there's actually something wrong. Because when you have the good day, you're like, oh, I'm feeling better. It's done. It's over. It's in the past. Whew, that sucked. And then 3 days later, you're back at the bottom of the barrel again. So that inconsistency, which I think is important for us to note with PMADs, and how easy it can be like, well, if I actually had depression, I'd be depressed every single day, all the time. So again, even as a clinician, you forget what you know when you yourself are struggling with mental health conditions. So I think all of these reasons, they contributed to me staying silent.
And depression doesn't always feel like what we think it should feel like.
Yep.
Especially you being a clinician, I think can be some denial that comes in. It's like, it couldn't possibly happen to me. I know what this looks like. And then, yeah.
You can't see it when you're in it. And so that's why, in the work that we do, we talk with pregnant people all the time about like, let's make a plan for postpartum. And they're often like, no, I got it. It's going to be fine. It's like, well, let's just make a plan now so that if things go awry, you don't have to think about it. Because once you're in it, it's really hard to see the forest through the trees, right? And it becomes your normal. And I think for the people around you also, it's harder to see the difference because it's been this like, for many people, not everybody, but for many people, it's like this slow progression. And it's not just you were fine yesterday and today you have a rash all over your body, right? There's no physical symptom that you can check off on a list. And so it makes it complicated for providers to recognize, families to recognize. It's not a 1, 2, 3 checklist. It is listening, asking questions, being curious, building that relationship where you might have felt safe enough to share those deep, dark feelings that held a lot of shame and guilt. That doesn't happen in a 3-minute appointment with a provider who just comes in and leaves. It takes time.
Yeah. And if I bring all of that, as I always do, how it informs my work as an advocate, as an educator, as a clinician, I do a lot of training and psychoeducation now with Postpartum Support International and beyond when it comes to screening and talking about best practices in screening. I'm always careful to acknowledge that providers that come in contact with perinatal people, let's say OBGYNs, for example, I'm very mindful of the fact that they are like boom, boom, boom all day, patient after patient. This is our healthcare system. And so I am cognizant of the fact and empathetic to the fact that it can be difficult to have a full-on conversation. And at the same time, there are very simple things that we can do as a provider to grease the wheels, if you will, and open the door and allow it to feel more safe for somebody to be honest, even if it's just starting with a couple facts of normalization. One of the things that we're going to be doing in our work together while you prepare for baby is staying on top of your physical health, which is critical, but your mental health is just as important. And one of the ways that we're going to keep an eye on it is that I have an assessment that I use with all of my patients a couple times throughout their pregnancy just to check in and see how they're feeling. I want you to know that even though we don't think postpartum depression or anything is going to happen to us, it actually happens to 1 in 5 new and expecting mothers. So it's really important that if a mom is struggling with her mental health, the sooner that we can identify it, the sooner we can get her the help and care she needs and deserves. So would it be okay with you if we took a few minutes to do this assessment together? It took me 2 minutes, not even 1 minute maybe, to deliver that message and then go through the questions.
Yeah.
Which is so different from normalizing. I feel like so much focus has been on normalizing how hard it is. And it is. Being a parent is very hard and your life changes, but saying like, oh, it's normal to not get sleep, or it's normal to be sad, or it's normal to feel overwhelmed. Well, let's talk about it instead. What does that actually look like for you? Feels really different than just validating how hard it is.
Yeah. And you're right. Our system is not set up to allow that kind of thing to happen so easily. And there are things that hopefully we can continue to do so that providers feel like they can take the time to ask those questions. And what I've heard from, I'm sure you've heard this from OBs, is if they do ask the questions, they know what to do.
Yes.
With the answers that they get. They know where to send somebody. It is a terrible feeling to identify a problem and then not know what to do about it because there are no resources available.
Right. Absolutely. And also, it's interesting, over the years, I've really changed my tune around whose job is this anyway. And I used to be, 10, 15 years ago, very much on the side of OBGYNs, it's your job. You have to do this. You are the discipline that comes in contact. You need to screen, you need to educate, you need to do all of that. And I have since, while I still absolutely think that this work belongs in that space, have become such a fan and supporter of models that now exist to integrate behavioral health care. So the collaborative care model, integrated care, where we have behavioral health professionals embedded in an obstetric practice that are responsible for psychoeducation, screening, short-term and long-term therapy, referral, resources. And that takes the onus off the OBGYN to have to cover all of those pieces along with what they're trained to do. So I'm really hopeful that we see these models take off. And, interestingly enough, OMH, New York State Office of Mental Health, they really have been committed to improving perinatal mental health outcomes, and was proud to be one of the leaders on a report that was released at the end of last year, New York's Maternal Mental Health Recommendations and Report. And one of the initiatives coming out of that is to fund collaborative care models across the state. And so they're in a funding round right now to provide small startup grants to 17 OB/GYN practices across the state to be able to bring in a behavioral health care manager, have a prescriber that can help give them direction and consultation on prescription and med management. And we have billing codes to go along with it, right? So these are not impossible models to recreate everywhere so that we start to better fill those holes and gaps in care.
Yeah. Wouldn't that be amazing?
It's that wraparound program, seeing something from many different angles, all under one roof. Then someone's less likely to fall through the cracks, and it's not that much more expensive. I mean, I don't fund programs, but these are all things that we have already. There are behavioral health experts. There are pediatricians. There are OBGYNs. We can have them close together.
Yes.
Right. I mean, I think if they can figure out how to do a 3-hour glucose test and keep somebody in the office and test their blood every hour, we can figure out how to screen somebody for depression and anxiety in pregnancy and postpartum.
And there you go, Pauline. Like, what a great window of opportunity. If we had a video that, was a requirement for patients to watch while they were waiting for their glucose exam, if it became standard practice to provide people with a brochure or a pamphlet, I know these things aren't going to capture everyone, and they're not, that alone might not make a significant difference, but you have somebody in your office for however many hours sitting there. Why don't we take advantage of that window of time exactly and provide some psychoeducation? That would be a wonderful window.
Where there's a will, there's a way.
That's right.
And Paige has the will, as do many of us. So we are all working together so that no mom is like, nobody ever told me this could happen.
So, Paige, what is the thing going back before this was your role, your career, like it is now? What's the one thing that no one told you that you wish you had known?
Well, interestingly enough, it's what I sought out to do and am currently doing. I'll answer that in a two-pronged way, personally and professionally. I wish personally that somebody had seen me, laid eyes on me, and said, I know what you're going through. You're not alone. This happens to so many people. I've got your back. This concept that I always share with new mothers that I think gives them a sense of relief because it's what they long for. I say, never is there ever a time in our life where we desired to be mothered more than when we are becoming a mother. And God, I wanted the proverbial mother to scoop me up on her lap and hold me and rock me back and forth and tell me it was going to be okay. And I've spent years of therapy working through giving myself that. So personally, that is what I wanted. Professionally, I wish that as a social worker who is moving through the School of Social Work and getting my degree, that there was a course on perinatal mental health so that if it happened to me, I would know. Hence, fast forward, I'm teaching a class at the Silberman School of Social Work at Hunter College. It's one of the first perinatal mental health courses. There's very few in the country. We're in the process of trying to publish a book to accompany the course, and we're turning it now into a year-long trajectory. So that social workers and hopefully other disciplines, right, will be able to access this education so that when they go into the field, they know what to do. And as we know, so many people that are drawn to this field do so because of their own lived experience. So you got a little bit more than one answer there. But that's what I wish someone had done for me in both of those ways.
So you said it, and we're putting it out there. Thank you so much for being here with us today. And thank you for all of the work that you are doing. We are not going to stop having babies.
Well, I am. I'm done.
Me too.
Not we, the people in this room. We, the greater community.
The human race is not done.
The human race is going to keep having babies, and we're not going to stop until this is not a problem that people are doing alone.
Exactly. Wonderful, wonderful words. And I just want to thank you, Pauline and Megan, for being such wonderful co-hosts and for leading such an important conversation for everybody who's listening.
Thank you, Paige. And maybe we'll have you back another time to talk about some of your other parenting experiences.
Oh, would love to, because now one's 20 and one's 17, so I've got all kinds of observations.
Yeah, we're the been there, done that moms.
Yeah. But it feels like yesterday.
Yeah, I'm in the middle, so Not quite to the college age yet.
You can see it on the horizon.
Yeah.
Well, thank you so much. It's been fun. And we will definitely bring you back for some more.
Sounds good. Thank you both.
Thank you,
Thanks,
Paige.
Paige. Thanks for spending this time with us.
This is what No Mom told you. And yeah, there's more where that came from.